Great. Okay. So what we're here really to discuss primarily the services we might provide to our patients, our service users who self-harm. I mean, it's focused this program mostly on the community, but I know colleagues, are working across the care pathway, and we'll hear from all aspects at every point along the care pathway. There is, we can do stuff, we can improve stuff. But this is what I'll talk about over the next 40 minutes or so. I'll start with a little bit of context, tell you about the kind of current NHS England led programme, think about the different settings we might provide self-harm care in, talk a little bit about some of the research evidence and what that tells us about our main areas of focus, and then a little bit about self-harm and the pandemic and where we, I suppose, go from here now that the initial phases, at least, of the pandemic are over. So let's start with a little bit of context. I always like to start with a little bit of historical context, and I've been working in self-harm services for maybe 25 years or so. And when I started, I worked with this chap here. He's a liaison psychiatrist, now retired in Leeds. And back then, services for self-harm really weren't very good at all. And I think over the years, they've improved quite a lot. I mean, there is a little bit of a kind of difference of opinion. So my old mentor, this was published a couple of years ago in the British Journal of Psychiatry, thinks that really we haven't made any progress at all. I argue, I think that we have. Things are certainly a lot better than they were, but we still have quite a long way to go in terms of the care we provide for people who have hurt themselves. The other thing I think that has changed in recent years is just the priority self-harm's got, in policy terms, in clinical terms, in service development terms. Lots of reports from College of Psychiatrists, House of Commons. We'll talk a little bit about guidelines and the Samaritans report in a second. But if you like, there's a big, lots of attention around self-harm, a real opportunity to intervene, to make a difference. A little bit about what we mean when we talk about self-harm. Sometimes, when I'm talking to non-specialist colleagues, there's a bit of confusion. What are you actually talking about? When we use the NICE definition. So sometimes when you talk about self-harm, people think, oh, it's just self-cutting. But actually, what we're talking about is something much wider. It's self-poisoning. Where I work in hospitals, that's actually the commonest form of self-harm. In the community, it's self-cutting or self-injury. And we use this kind of intent-free definition. Sometimes people say, well, when you say self-harm, you don't mean attempted suicide, do you? You mean non-suicidal self-injury. And actually, our definition of self-harm, the way NICE view it as well, is it's everything. It's irrespective of apparent motivation or medical seriousness. Why do we view self-harm like that? It's because often it's not easy to separate out exactly what people were intending at the time. When they're in distress, their motivations are ambivalent, their motivations and intent changes. And the other thing we know is that even people who are labelled as non-suicidal, when you follow them up, are at greater risk of suicide in the long term. So we have this kind of, if you like, this wide catch-all definition. And really the main thing with that is to make sure that people aren't excluded. There's a lot of it about. It's a very common cause of hospital presentation. So one of the commonest causes of hospital presentations, over 200,000 episodes in England, 150,000 people. So it's very common. And the other big thing, of course, is its link with suicide. So this is a paper we did a little while ago, self-harm in older adults. A reminder that self-harm doesn't just occur in young people. Sometimes people think, well, self-harm just a problem in young people, but it can occur across the lifespan, and particularly in older adults, but actually across the range. For anyone who self-harms, they're at much higher risk of suicide, sadly. So in this study, older adults who self-harmed were 145 times more likely to die by suicide than the general population. So, really important link with suicide. But even though self-harm can occur at any point across the age range, if you like, the antecedents and what we might do about self-harm kind of does vary. So in older adults, we know that a psychiatric illness is more common. Physical illness can sometimes be a factor in self-harm. Social isolation and bereavement are also important, precursors or antecedents. So, if you're thinking about targets for intervention in older adults, they're the targets for intervention. In younger adults, could be educational pressures, interpersonal problems, relationships. So self-harm occurs across the across the lifespan, but interventions will vary. So we've got this issue that's pretty common. It's common in the community. It's also common in health services. It's got potentially serious consequences associated with suicide. How do we do in terms of management? And the answer is, well, although things I think have improved, not brilliantly, we still don't do brilliantly in terms of service provision for self-harm. And this Samaritans report, which came out in 2020, summarizes it really good. Summarizes really well. The title, pushed from pillar to post, I think summarizes it brilliantly. So it's this idea that services are fragmented. Someone who self-harms might bounce around between community mental health teams, a GP, may be referred into talking therapies but don't meet criteria. This idea of fragmented services, I think, is really important. So we've got to do better. And that's really where the current programme comes in. And in terms of where it fits, so it's really the idea of improving community services for self-harm is really part of your community transformation for mental health work. So that's where it sits. And the idea, as I think many of you all know, behind the community transformation work, it's part of the NHS long-term plan, is really a better integration between primary care, between general practice and specialist services. So the aspiration is a kind of seamless service, so single point of access, a seamless service between primary and specialist mental health services. And there's been significant investment in terms of funding, about £1 billion extra per year, and quite significant investment, quite significant service provision. So in terms of, sometimes people are asking me, well, Nav, what new funding is there to support our community self-harm work? It's actually part of the funding, organisations have already received for the community mental health transformation. So no, I'm afraid, dedicated funding for the self-harm work, but there should be, it should be considered as part of community transformation work. And if you're not linked in with your local community transformation needs, you need to be, because that's where hopefully some of the resource to support you will be coming from. And the aim, really, the ask from NHS England to every area in the country is to think about your plans to improve community services for self-harm. So I think a lot of that is harnessing what's already going on in various areas, and there is an awful lot going on, and turning it into a plan. So what is the plan going forward for improving care? What's our role with that? Our role at the Centre for Mental Health and Safety, our role at the National Confidential Inquiry into Suicide and Safety, really it's to support you with the evidence, so we can give you a good indication of what works, what doesn't. We're a kind of leading research centre. We're also really happy to comment on your plans, and really nice to hear that there's colleagues from data analytics here today, because thinking about measurement is really important. So how are you going to measure that what you've done or what you're going to do is effective? Thinking also about how you implement. So it's not just a case of implementing it. You might want a quality improvement type paradigm, but thinking about how you implement, thinking about how you measure, and we're delighted to comment on plans. So how does that support get to you? Well, it's this, which is one of the virtual site visits. We'll be in touch with you by email. There's a website. Shared learning, so you guys are phase 2. On the website there's an indication of what's gone on already, and we encourage we're encouraging areas to learn from each other, to steal from each other. So it's really, really important. The other really important aspect of this that's really kind of taken off, and Leah, who's on the call, is leading these, are the interactive kind of clinics. So monthly, more informal events where we take a topic, safety plans or primary care, or service user involvement, and we have maybe one or two kind of experts talking, and then we hear from you and kind of troubleshoot and tackle problems. So Leah runs those, and there's a kind of list of those that we can circulate. So I mentioned the website. Here's the website, the links here. All the slides will be shared after the meeting, and they're actually available on the website too. So you can click on that. I mean, it really kind of focuses on the evidence in different areas. So you can click on, well, what's the evidence on psychosocial assessments? Click on that. It will give you some of the evidence. Please do take a look at the website. I know some of you looked at it already. Tell us if there's other things you'd like to see on there. If you spot any errors or any suggestions for how we might improve that, because that's a live resource for everyone involved in the program, and more generally as well, so everyone's able to access that. I've also mentioned measurement. It's a tricky issue, measurement, especially of self-harm, just because of the way, and Caroline Clements, who's one of our other content experts, can kind of speak to this at great length. It's sometimes very difficult to know how much self-harm is presented to services, how much self-harm there is in your area, because it's difficult to code. Sometimes things are coded as other things. There are some, if you like, routine statistics you can use, presentations, admissions. You can be thinking about bespoke data collection, or data collection as part of routine activity statistics. There are some problems with those, but as a kind of indicator, they can be helpful. But there's other things you can use as well. So the implementation of what we know are quality standards for self-harm. So there's nice quality standards. There's about 8 or 9 of those that you can audit or look at to see whether you've implemented them. But also process measures are really important. So getting actual service user feedback, thinking about how well new services are being used. So, but measurement, a really important principle of this. Now, probably you're listening to me here and you're thinking, oh gosh, this is a big ask. I'm feeling kind of slightly daunted about this. Got to come up with a plan. How are we going to do it all? But just bear in mind that you aren't the first sites to have done this. So we worked with 10 to 12 early implementer sites last year, and they've done some of this. And on the website there are some infographics kind of summarizing the kind of areas of focus. This is from Frimley. They focused on psychological interventions after self-harm, again talking and thinking about how they're going to measure it. In Somerset, a lot of areas thinking about what the digital offer might be, how we can make that most effective, and again they've done some work around that. So if you like, you've got the early implementer sites to help you. The other thing, as well as the kind of early implementer sites, is to know about the things that will be going on in your own areas. So as of April this year, we're delighted to say there's a sequin for self-harm. So those of you who don't know what sequins are, they're, if you like, essentially health service targets to help kind of incentivize different bits of services. In this case, it's thinking about assessments. How do we improve assessments after self-harm by mental health liaison services? So it's not strictly focused on community services. This is, if you like, hospital services, but it's complementary to the program we're talking about today. In many areas, it's the same people working on this program and working on the sequin, but if it's not, I encourage you to link up with the people leading on the sequin, because obviously, what happens in hospital is complementary to what's happening there in the community. But really delighted that finally we've got a sequin that really seeks to improve assessment after self-harm. So that's one existing program to kind of be slotting into. The other existing program is the major quality improvement program for suicide prevention that's been going on for 3 or 4 years now. Again, funded through NHS England. We're providing the academic support. 3 priority areas for that. Remember, that's focused on suicide prevention, mental health patients, men in midlife, primarily in primary care, but also self-harm services. So as part of the suicide prevention work, self-harm is a priority area. So there will be work going on in self-harm as part of that program. Again, for many of you, you're the same people. You're involved both suicide prevention program and the self-harm work. But if you're not, really encourage you to link up with colleagues who are working in that space. So linking up with what's going on already, I think, is a really important principle here. Another, of course, overarching kind of principle is just making sure that you've got, good service user and carer involvement and also engagement. We know it's important for mental health research. We know it's important for mental health services. And I would say for self-harm, it's even more important. Certainly, when we've run training events, people providing care will really listen to someone that's been through a kind of care pathway much more than they'll listen to people like me. So getting service users and carers involved. And when we had our launch event for this program back in October, and the videos are on the website, Dr. M, who's our service user rep on that, which she did a absolutely kind of tremendous talk, which brought home why we're kind of doing this and why we need to improve services. So service user and care involvement, really crucial. Let's talk, so we talked a little bit about the context. Hopefully now you're aware of also where the kind of current program sits, and it kind of sits kind of on its own, but actually linking with lots of other things and is part of the community transformation work. I want to talk next about settings. So some of you will have seen me put this up before, this Iceberg Model of suicidal behaviour. So it's the idea that suicide and self-harm are part of a kind of continuum, and they're part of an iceberg. At the top, you've got suicide presenting services, but then under the waterline, sometimes hidden, you've got self-harm in the community. And really, this programme is about, what you provide at all of those levels. So, it might be thinking about people on mental health service, community mental health service team work caseloads who don't have access to psychological interventions because it's not something traditionally we've provided at scale. People who present in crisis but don't get follow-up in the community, again, think about what we might provide there. And I know colleagues will be talking about particular initiatives, particular patient groups. But then also thinking about what we provide, in the much bigger group in the community, people who maybe present to primary care, people who actually don't come to the attention of services. What might we be able to do for those individuals? So it's at all these different levels, but it's also thinking about groups who might have particular needs. So young adults, aged 18 to 25. This program itself isn't focused on children and young people. There are other programs going on, other bits of community work that are focused on community and young people. But obviously, if you're thinking about self-harm services in your area, you're going to be thinking about not just young adults age 18 to 25, you're going to be thinking about children and adolescents as well. Older adults, we've talked a little bit about suicide risk, particular needs. People from minority ethnic groups with specific needs who we know are less likely to access services. So, again, a really important group. Varies from area to area. In some areas, that's the most important issue. In other areas, it's one of a number of really important issues. People from LGBTQ+ groups who we know might be at higher risk and often get poor services. So thinking about it at different levels, thinking about what we might offer to different groups. Just talking about that, some of that kind of ethnicity data, paper published last year, led by my colleague Bashir Farouk. This is young people from ethnic minority groups in Manchester who self-harm. And I mean, the big story there was a lack of access to care. So compared with white young people, they were less likely to get an assessment. Now, everyone's supposed to get an assessment after self-harm. So young people from ethnic minority groups, less likely to get an assessment. That's a big deal, I think. More likely to just be discharged without any follow-up, less likely to access mental health care. So access, I think, is really important for some of these groups. So when we're talking about settings, I think one of the big opportunities for us, in the coming years is thinking about primary care, thinking about general practice as a setting for mental health care and a setting for self-harm and suicide prevention. I think that's a real kind of untapped frontier. This is data a few years old now, but a really big study led by my colleague Matthew Carr, big national study looking at self-harm in primary care, and looking at self-harm by deprivation. So what this shows is the people who lived in the most deprived areas, so deprivation quintile 5, had the highest rate, highest incidence, if you like, of self-harm. So that's one of the things we know. We know deprivation is associated with poor mental health. We know, sadly, deprivation is associated with self-harm and suicidal behaviour. So we know that. But really important nonetheless, the importance of tackling inequalities. What's, I think, very striking is then when you look at the percentage of people referred to mental health services by deprivation quintile. So people in the most deprived areas are most likely to self-harm, but least likely to get referred to specialist mental health services. So it's this idea, it's called the inverse care law in public health. Those of you familiar with the kind of public health provision, inverse care law, people most at need often have the least access to healthcare. So general practice, really important potential area. Inequality is something we really need to tackle. What do we do in terms of suicide and self-harm in general practice? Well, there isn't a huge evidence base. This is a systematic review by my colleague Faris McGaw in Keele, from Keele, and well worth a look at. You know, some of the facilitators to helping people in general practice, you know, proper training, improved communication, involving people. Some of the barriers will be familiar to you, you know, kind of referral thresholds, not having services in place. Well worth a look at, thinking about how we improve things in primary care. Another setting, so remember we're talking about settings, another setting of course is education, where, you know, a lot of young people are, so whether that's universities, in your patch, a lot of areas, you know, have big universities in their patches, and that's, I think, a really important aspect to this. Or whether it's kind of home. Lots of kind of resources out there for parents and kind of carers, thinking about, you know, what the support might be in those settings. So it's not just health, it's not just health and care, healthcare, education, but also the third sector, crucial partners in all of this. And you know, one of the things that really has changed in recent years is the involvement of our third sector colleagues in direct service provision. So the Samaritans locally here in the Northwest provide a follow-up service for some people after they've attended the emergency department with self-harm. Harmless, charity, I think well known to you, based in Nottingham, directly involved in both service provision and training. So really important that you link with third sector colleagues and providers. I think, you know, they're crucial in all of this. Okay, we've talked a little bit about the context, we've talked about the current programme, we've talked about the different settings in which you might want to improve your offers. Let's talk a little bit now about the evidence. And in one way, we're really lucky. I mean, you often hear people say, well, there's not a lot of evidence around, you know, what works and what doesn't for self-harm. In some ways, that's true. But actually, you know, I think there's enough evidence to guide us to what we need to do now. And one of the good things is, you know, if you like, that research is summarised in the NICE kind of self-harm guidelines. I'm slightly biased. I kind of chaired them. I've been expert advisor to them. You know, I'm quite heavily involved in the NICE guidelines, but I am a fan of guidelines because they kind of summarise the evidence, hopefully help us to focus focus our attention and our evidence based as far as possible. So they're based on the research evidence as far as possible. So, you know, 2004 was the first NICE self-harm guideline. We're currently redoing the self-harm guidelines, expected publication over the summer. So we've got the guidelines to guide us. Training is something that comes up again and again and again. I'm asked, which is the, you know, what's the best evidence-based training? We don't recommend specific kind of training, but a couple of years ago, in response to some of our Health Education England asked us to develop some competence frameworks. So what competence frameworks? They're an indication of the key skills, knowledge and attitudes that we would expect staff to have if they're trying to help people who have self-harmed or have suicidal ideas. So evidence-based as far as possible. Encourage you to have a look at this. You click on the boxes and it tells you, well, what knowledge and skills would we expect staff to have? So what we've said to areas is either, a lot of areas are providing their own in-house training, which some of it's absolutely brilliant, but you can audit your training against these competence frameworks, look for gaps, look for areas where you might want to kind of strengthen your training, or use it as a basis for developing kind of training. So either auditing your existing training, developing your own training, but the competence frameworks are there for you to look at. Adults and older adults. It's another one on kids and another one for non-specialist staff. In terms of what the research evidence kind of tells us where the main areas of focus might be, one of them is just making sure that everyone above, if you like, that waterline, or even people presenting to primary care, get an assessment. So they're properly assessed. And why is that important? Well, we know just that assessment can reduce the risk of someone repeating self-harm by about 40%. You might be thinking, well, hang on, what is it about just that assessment that might work? So this is some great work carried out, big qualitative study carried out by Leah, thinking about talking to service users and carers and thinking about what actually helps during a psychosocial assessment. So there's stuff in there about the assessment itself. So it's humanizing care, it's collaborative, it's space and time talk, it's compassion and reassurance. It's actually feeling the clinician or the professional or the worker is actually listening to you, connecting, you're having space and time to talk. So something about the interaction itself, but there's also something about kind of plugging people in. So if they get a proper good quality assessment, you plug people in to the care you need. So I encourage you to have a look at that paper, but making sure that people who self-harm get an assessment is a really important area of focus, but also making sure that we have we've got talking treatments available too. So making sure that we can provide kind of psychological interventions for people who self-harm. Why is that important? Here's sometimes people put up complicated slides and apologise for them. I'm not going to apologise for this, because all I want you to look at is this black diamond. What's this? This is a forest plot. So it summarises lots of the studies, lots of the trials looking at psychological interventions after self-harm. And the bottom line is, when you kind of, if you like, consider all those results together, on average, getting a talking treatment after self-harm reduces the risk of repetition by about 34%. Okay, so just the talking treatments. People often ask, well, what talking treatment should we provide? In the Cochrane review, which is what this is based on, they're called kind of CBT-based psychotherapy. That's probably a bit of a generalization. There's lots of different things here: problem solving, interpersonal therapy, cognitive therapy, behavioral therapy. But it's basically therapies or talking treatments that are tailored for individuals in self-harm, but a really good thing to provide. Up until recently, no service in the country routinely provided psychological interventions after self-harm. I'm pleased to say, some areas are now beginning to provide that. And again, this is one real area for focus: psychological intervention after self-harm, making sure people get the treatments they need. One of the really important things to say is, if you're going to intervene after self-harm, you've got to do it quickly. Why do I say that? This is some data from the Manchester Self-Harm Project. It really looks at, if people are going to repeat self-harm, how quickly do they repeat? And the answer is, they repeat early on. They repeat quite quickly. So what this is showing is 30% of people who repeat self-harm within a year repeat within the first month. And actually, 10% of people who are going to repeat self-harm within a year do so within the first 5 days. So this idea that we can send people an outpatient appointment in a month, etc., is a bit of a waste of time. If we're going to intervene, we need to do so swiftly. So that's psychological interventions. The other thing that comes up again and again are safety plans. So for those of you who aren't familiar with it, well, this is, basically perhaps at the end of an assessment or as a person's going to be discharged to community services, the clinician might sit down with them and develop a safety plan. So that would be thinking about, warning signs and contingencies should they feel feel in crisis again, who they're going to go to support, which professionals and agencies are they going to contact. Safety plans are available kind of as apps. They're also available, of course, as pencil and paper things that are filed in service users' notes. They're very now widely used. The actual evidence behind them is actually quite mixed. There's not been a major UK randomised trial. So the way we would kind of test treatments. There's been a pilot trial that's about to publish. But the evidence is kind of, in some ways, it's surprisingly kind of thin. A couple of reviews have been published in recent years. I mean, they suggest, and also, it'd be my view that these things are potentially really quite helpful. So safety plans are potentially really quite a good idea. But with a lot of these things, assessment and other things, it's not, about the exact questions you ask, the exact app you use, or the format you use for the safety planning. It's the how. So is it done in a kind of collaborative way? Are patients feeling, are service users feeling listened to? How should we be doing safety planning if we're doing safety planning? This second review has a few kind of tips. I mean, they talk about the most valuable safety plans being accessible, both to the service user, but also in services. Sometimes if you're wading through electronic records, you can't find the safety plan. So making sure they're accessible, making sure they're personalised. So not a kind of tick box exercise, it's personalised to the individual, involving others, involving patients and carers and their families, if at all possible, if that's appropriate, and making sure it's a collaborative process. So it's not, the clinician or the professional, saying, well, this is what you should do if you are in crisis again. It's a kind of collaborative process that's also owned by the service user. So I think safety plans, good idea, but thinking about how we provide safety plans. There's also kind of existing work that can kind of guide you. So this is some of the original guidance from when it was developed in America. As part of the phase 1 projects at Cornwall and the Isles of Scilly, did a bit of work thinking about how they developed safety plans and what they did with that. And there's also, you can look online. This is some safety planning guidance from Oxford, colleagues in Oxford who run a really great service. But there are some of the things to look at if you want to know a bit more about safety plannings. And again, all the links will be available. Safety plans are one thing that have come up a lot. The other thing that comes up a lot is, especially given our experience over the last couple of years, is, well, digital interventions. Are digital interventions the answer? If we've got people self-harming, if we've got people in distress, is that the answer? And one of the things about research is people can largely review the same bit of research and come up with slightly different conclusions. So these are 2 reviews of digital interventions. So this is friends and colleagues in Australia. So, quite enthusiastic. Disseminate them widely, especially where there's a lack of a minimal access to health services. These authors a bit more cautious, saying, well, you need further research, and you need to think about the risk-benefit ratio of digital interventions for these individuals. And I think that's right. We sometimes people think, well, we can't do any harm, can it? This kind of intervention, or this kind of simple intervention. But I think sometimes interventions, even simple ones, can do harm. So we do need to be aware of the risk-benefit ratio. My own view is that the evidence suggests definitely digital interventions can be helpful. But going forward, it's really about kind of choice. Initially, my thoughts were, well, everyone's going to want to get back to face-to-face, aren't they? But I don't think they are, and digital interventions offer some real kind of accessibility advantages. So for me, the watchword, if you think about your digital offer, is kind of choice. So for some people, digital is going to work, and the same principles kind of apply. You want to kind of engage people as much as possible, but some people will continue to prefer face-to-face. Okay, there are some things that I think are quite a good idea. Here are some things that I think are not a good idea. Risk tools and scales. So mental health services in particular, we're all obsessed with, scoring people on risk tools and scales. The problem is, especially after self-harm, the risk tools and scales aren't very good. So the bottom line from the research is the positive predictive value is 5%. What does that mean? That means if I rate 100 people as at high risk, only 5 of them are at high risk. So in other words, they're wrong 95% of the time. But that isn't the biggest problem. The biggest problem with these risk tools and scales is one of exclusion, because it's all the people that are rated as at low or moderate risk who, sadly go on to repeat self-harm or even die by suicide. You kind of miss all those because you rated them all at low risk. So the big problem with risk tools and scales is one of exclusion. So Leah on the call has done a lot of the work in this area. So it's not a good idea to be using them. And instead, it's about providing better care for all. So rather than trying to identify, the so-called high-risk people who have self-harmed, it's about providing better care, I think, for everyone. Just very quickly in the last 5 minutes, just talk a little bit about the pandemic. It's kind of difficult to remember back, back to kind of April 2020. I've kind of looked through kind of previous talks I've given through the pandemic, and it was just, we really didn't know what we were coming up against in terms of the indirect effects of the pandemic. What happened to mental health? I think it's pretty clear from the earliest studies. This was one of the early studies carried out by some of my colleagues in Manchester, that COVID and the pandemic did have an impact on mental health. So this was a study using self-report measures, and basically people's mental health got about 10% worse. So clinically significant mental distress, about 10% worse. How did that translate into self-harm? Well, thankfully we didn't see increasing rates of self-harm. In fact, when we looked at health service settings, we saw a big reduction in help seeking early on. So this is data from primary care, big study. Sarah Steig, one of our colleagues here, led on this. Big fall off in help seeking. Yeah, that might have been because we were encouraged at that stage, do you remember, to kind of protect the NHS, so people weren't coming forward. People were understandably frightened about presenting to health service settings. And there was also probably an accessibility issue there. So were mental health services kind of as accessible as they were before? But the other thing is we did see a fall in suicide early on in the pandemic. And so part of this might be a kind of genuine decrease, but a big fall off in hospital and primary care presentations. That occurred across the age range, but this is a kind of a subsequent study based in Greater Manchester. One group that I think is a bit of a worry in all this is young people. So from April 2020, this is people aged 10 to 17, again, primary care, self-harm rates seem to have kind of gone up, and that's a background against a background of suicide and self-harm rates in young people over quite a number of years going up. So I think it's part of a wider concern, I think, about young people. So there's a fall in help seeking to health service settings. What about community? What happened to community levels of self-harm? We don't have data before the pandemic. We have data throughout the pandemic, though, collected by colleagues at UCL as part of this really excellent study with thousands of people in. Basically, rates of self-harm in the community stayed more or less constant. This is a reminder that people with mental health problems have higher rates of self-harm than other people. But basically, there were no kind of clear trends there in relation to kind of lockdowns and easing of restrictions. So what we saw then is a fall in help seeking from health service settings, but community services, community self-harm staying the same. Question is, where were people presenting? One possibility is they were presenting to third sector colleagues. This is a study of telephone helpline calls during the early part of the pandemic. Shows that they increased. It's not UK data, it's international data. showed the increase, but actually the calls weren't about suicide and self-harm. The calls were about general concerns, about kind of finances, about worry about the pandemic. So possibly, you know, third sector colleagues, some third sector colleagues were telling us how they were picking up the slack early on, but going forward, they're going to be a really important part of service provision. And service provision did change. So this shows management of self-harm in primary care before, in a pre-pandemic period compared with the first 5 months of the pandemic. Obviously, basically, anything above the line shows pandemic changes. So remote consultations went up. Interestingly, there wasn't any evidence of digital or remote exclusion there. So consultations went up remotely for everyone, regardless of the deprivation level of the areas in which they live. The big thing, though, is referral to mental health services went down. So not only were people less likely to refer, when they did refer or when they did present with self-harm, they were less likely to be referred to mental health services. So I think, yeah, this double whammy of, you know, reduced service provision, certainly early on in the pandemic. So no evidence of exclusion. One of the other interesting things is young people early on were more likely to be prescribed medication during the pandemic than pre-pandemic. So medication was a more common response to self-harm then. So important changes to our service provision. But of course, I think what's going to be important going forward is some of the things that have nothing to do with COVID. I mean, partly they have their roots perhaps in COVID, but economic factors. Economic factors, you know, we know are really bad for mental health. They're really bad for kind of suicide rates, and they're really bad for self-harm. So thinking about economic factors, thinking about economic pressures and how they might have an impact, and being prepared and thinking about what we might do to mitigate those. So I've told you a little bit about the context. Hopefully you know now where the current programme sits in relation to all the other work you're doing. You'll need to think about your offer across different settings, talk about evidence, so safety plans, psychological interventions, making sure people get an assessment, but probably not relying on risk assessment tools or ratings of risk. And a little bit about self-harm and COVID-19, this, if you like, lack of kind of service provision early on in the pandemic, thinking about how that's going to play out longer term, and thinking about what our response to the kind of inequalities and deprivation is going to be. So thanks very much. Just always like to put up a slide of all our kind of hardworking staff. We don't manage to capture all of them on the photograph. Some of them are a bit elusive, and obviously Jessica and Pauline, who've just joined on this slide yet, but they're the people that do all the hard work. So I'll